High-dose biotin causes a multitude of false lab tests, and it's not at all just thyroid tests. High-dose biotin can cause a multitude of false lab tests, masking recent heart attacks, pregnancies, or allergies, giving false signals about tumors, and far more. And this is all about that and what to do. If you would like to read the written version of this podcast, you can do so over on Substack using the link in the description. If you subscribe to Substack, whether free or paid, it doesn't matter, you will get my 7-page quick guide on how to not get sick this winter called Staying Immune Through the Winter. Please remember that I am not a medical doctor and this is not medical advice. Biotin is a B vitamin, also known as vitamin B7. It plays a critical role in energy metabolism, neurological health, and blood sugar stability. It is widely used as an over-the-counter supplement for hair, skin, and nail health, and is currently being studied in very high doses as a treatment for multiple sclerosis. Despite the many benefits of biotin, high-dose biotin supplements can cause false signals on a multitude of lab tests. This has the potential to mask recent heart attacks, pregnancies, or allergies, to misdiagnose thyroid conditions, to give false signals about the presence or progression of tumors, to falsely raise vitamin D, vitamin B12, and folate levels, to falsely alter many hormone levels, to generate false positives for HIV and hepatitis, and it has led to at least one unnecessary surgery and possibly to one death. At least one death. So in this podcast, we are going to examine the nature and scope of the problem and what we need to do to deal with it. So first of all, what is a high dose of biotin? Because remember, this is not about low doses or medium doses of biotin. This is about, broadly speaking, high doses of biotin. There is no officially recommended intake for biotin, contrary to what you may find where people misinterpret the AI or the adequate intake as a recommended intake. But the current guidelines used in the United States took the average intake of American infants, adjusted it upwards based on body weight, and concluded that 30 micrograms per day, quote unquote, should be adequate to prevent deficiency in adults. This is the adequate intake, or AI, which is set by the Food and Nutrition Board of the National Academy of Medicine when there is not enough evidence to set a recommended dietary allowance, or RDA. The FDA has, in turn, adopted this figure to set its daily value for biotin at 30 micrograms as well. The FDA's daily values are what are used for the labeling on packaged foods and supplements and are generally translated in some way from the DRIs made by the Food and Nutrition Board of the National Academy of Medicine, up until fairly recently called the Institute of Medicine. In high protein, you need more biotin, which I'll also link to in the description. I made the case that 30 micrograms per day is not enough for adults and that many people need between 150 and 300 micrograms per day, depending on how much protein they eat. I have simple food-based recommendations for getting enough biotin that are found in my Vitamins and Minerals 101 Cliff Notes, which are free for MasterPass members, and I'll give you a link in the description. They cost less than $3 to buy. Incidentally, 300 micrograms was used as the FDA's daily value until it was changed to 30 micrograms in 2016 to harmonize it with the DRIs that had been set over 15 years earlier. Many people are using supplements that provide far higher doses than this. A milligram is 1,000 micrograms, and many supplements contain between 1 milligram and 300 milligrams. This is between 1,000 and 300,000 micrograms, and it ranges from 3.3 to 10,000 times the values that are thought to be adequate in the various sources that I had just described for you. This is the range that will be referred to as high-dose biotin throughout this article. So anything 1 milligram and higher is high-dose biotin, and those doses can include up to 300 milligrams, as is currently used in trials to study it as a potential treatment for multiple sclerosis. How common are high-dose biotin supplements? In other words, we're starting to define the problem. What is the scope of this problem? The most recent comprehensive data for the United States show that the number of people using biotin supplements providing at least 1 milligram per day increased 28-fold between 1999 and 2016. In absolute terms, the use of high-dose biotin increased from 0.1% to 2.8%. Data for supplements providing 5 milligrams or more were not available until 2007, but between 2007 and 2016, the use of these supplements increased 7-fold from 0.1% to 0.7%. The prevalence was highest in women over the age of 60, 7.4% of whom used biotin at a dose of at least 1 milligram per day, and 2.3% of whom used a dose of at least 5 milligrams per day. In 2017, the Mayo Clinic conducted a survey of 4,000 patients who came in for routine blood work. 48.6% of these people responded to the survey. Among the responders, 7.7% reported taking biotin supplements. The respondents overall were 49 to 72 years old. Biotin users were 3 times more likely to be female. Nearly a third of them did not know what dose they were taking, and of the rest, over 96% of them took more than 1 milligram per day, and the most common doses were 1, 5, and 10 milligrams per day. We should note that, of course, the number of people who were taking biotin and didn't know it was way larger than this, and most of it was coming from multivitamins. That's sort of obvious. And, so obviously 96% of people who have any biotin supplement in their diet can't possibly be taking 1, 5, and 10 milligrams because there are so many people on multivitamins that have lesser amount. But the type of supplementation we care about is 1 milligram and higher, and that is what is accurately described by 7.7% of people in the Mayo Clinic survey who are in the age range of 49 to 72 years old and who are dominated by women over the age of 60, in whom we have very similar national data of 7.4% of them taking high-dose biotin. A collaborative study done by Weill Cornell Medical College and UCLA's Department of Medicine was originally made available in 2020 and published in final form this year. In a sample heavily biased towards dermatologists, who were 81.9% of the respondents, they surveyed 149 physicians and found that just under 43.9% of them recommended biotin to their patients, most often for hair and nail disorders. Notably, very few were recommending biotin for skin disorders, and none of them were recommending it for multiple sclerosis, although that is because almost certainly because the sample is heavily biased towards dermatologists. The dermatologists in the sample, remember those are 81.9% of the respondents, were 2.6 times more likely to recommend biotin than any of the other physicians who were, or than the rest of the physicians who were surveyed. While 62.5% of the physicians knew that biotin can interfere with thyroid function tests, not the actual function of the thyroid, and 58.7% knew that it could interfere with cardiac markers, only 7% knew that it could interfere with pregnancy or vitamin D tests. Less than 3% knew that it could interfere with HIV and hepatitis testing, and a whopping 19.5% were convinced that biotin didn't interfere with any testing at all, which is just flat out wrong and indicates a complete lack of knowledge that the problem exists. Since the sample was enriched in biotin prescribing dermatologists, it probably overestimates the knowledge of this issue among physicians more broadly. Presumably, the physicians who are not recommending biotin at all know less about it and are less conscious of this problem, and they're not creating the problem by recommending biotin, but they're also not doing anything to solve the problem that definitely exists in their practice, which is that their patients are taking high-dose biotin and they're not asking about it and they're not telling them to stop taking it before lab tests. Thus, physician knowledge of this issue is very inadequate, and most patients are likely to be totally and completely unaware of it. All right, so that is the scope of how common the problem is. Now let's dig into the nature of the problem and its scope in terms of not the people it's affecting, which we just covered, but its scope in terms of the lab tests that this problem affects, how bad it is, what is the magnitude that your tests could be off for a given dose of biotin, and finally, what can we do about it? All right, so how biotin generates false measures on lab tests. We're going to cover the mechanisms of this interference now. But first, at a bird's eye level, the reason that high doses of biotin can generate false measures on lab tests is that many lab tests use biotin as part of their internal machinery to test the level of the other things in the blood or urine. Since high-dose biotin supplements can cause a much greater than normal level of biotin and its breakdown products to appear in the blood and urine, this can mess with the internal machinery of the test. Specifically, this is a problem with biotin-based immunoassays. Immunoassays rely on antibodies to detect many other types of molecules. Compared to other methods such as liquid chromatography, immunoassays are more likely to have problems with accuracy, precision, and interference. However, they are extremely common because they are well suited to run large volumes of samples per unit time with minimal technical skill required from lab personnel. Since personnel are the most expensive input into the costs of lab tests, using immunoassays, which requires little personnel skill, saves a lot of money. Most immunoassays use biotin as part of their internal machinery. For example, a 2018 paper by the Canadian company Calgary Laboratory Services reported that, quote, "We are a relatively large laboratory with an annual volume of 25 million chemistry tests," end quote, and that, quote, "most of our immunoassays are vulnerable to biotin interferences," end quote. And I just reiterate, most of our immunoassays. So basically all the immunoassays, which are one of the major types of assays used in clinical testing because of their cost-saving nature, most of them are biotin-based. The reason biotin is used in these assays is to exploit the principle of the tight binding between biotin and a group of structurally related proteins known as avidin or streptavidin. The origin of this principle is found in early experiments in the 1920s and 30s, leading to the phenomenon known as egg white injury. In the budding field of nutrition science, early findings suggested that egg whites could not provide adequate protein for the growth of rats. However, a paradox emerged, showing that small amounts of egg white did allow for maximal growth, while large amounts did not. This suggested that there was something toxic in egg white. Eventually, it was discovered that egg whites contain a protein now known as avidin, which binds biotin and prevents its absorption from food. Thus, large amounts of egg white were causing biotin deficiency. Subsequently, in the 1950s, scientists realized that they could use avidin as an experimental tool. Since it bound tightly to biotin, they could use it to purify biotin and biotin-bound enzymes and to study where those things went when they moved around inside cells. That is, they could study their localization. Then, in 1980, scientists published the first method to expand its use into immunoassays to measure all kinds of things. It turns out that there are likely over 100 avidin-like proteins, and they are found not only in the eggs of birds, amphibians, and reptiles, but are also made by fungi and bacteria. The form made by the bacterium Streptomyces avidinii is known as streptavidin. The many different versions of avidin are called homologs. Since the bacterial forms are most often used in modern immunoassays, the whole group of homologs is often referred to in the scientific literature collectively as streptavidin. The bond between streptavidin and biotin has several properties that make it ideally suited to use in immunoassays. Number 1, the bond is very specific. Apart from biotin and its derivatives, streptavidin binds very little else. And in fact, the bacterial streptavidin is even more specific than the egg white avidin. Chemical bonds can be broadly categorized into covalent bonds, where if two things join together, they become a single molecule, and non-covalent bonds, where the two things can join while maintaining their own chemical identity. And the way that works is covalent bonds involve sharing electrons, and other forms of bonds do not. The bond between streptavidin and biotin is the strongest non-covalent bond between a protein and another molecule ever identified. Number 3, the bond is very resistant to changes in pH and to chemicals used in lab assays that tend to break many other bonds. And then finally, number 4, since biotin is a very small molecule, it can link things together within the assay without obstructing other processes that need to happen to complete the measurement. All of these properties make the biotin-streptavidin interaction something that could be exploited across immunoassays because it is so useful. Soon after their development in 1980, biotin-based immunoassays became very common. The first case of biotin interference in these assays was reported in 1996. An infant was proactively given 10 milligrams of biotin along with 20 milligrams of thiamine and 10 milligrams of riboflavin because her sibling had died of an unknown metabolic disorder 2 years earlier. This caused the infant's TSH to appear falsely low and her free T4 falsely high in routine screening. The FDA first issued guidance about biotin interference with lab tests in November of 2017, 21 years later, and it has reiterated the guidance numerous times since. The first issuance was in the year following the receipt of a reported death. A multiple sclerosis patient had been taking high-dose biotin. After an acute episode of apparent heart attack, the patient had low cardiac markers that may have been falsely low as a result of biotin interference. If this is correct, it may have played a role in improper treatment decisions that led to the patient's death. In other words, the patient had symptoms of a heart attack, but since the blood work suggested that the patient didn't have a heart attack because biotin was falsely suppressing the cardiac markers, they didn't treat it as a heart attack and the patient died in ICU. However, there was too little information in the report for the FDA to actually agree with it. But because reports of interference with cardiac markers kept coming in over the course of the next year, the FDA finally issued guidance in November of 2017, about a year or so after the initial report of the possible death linked to this phenomenon. Since, and I mentioned there may have been at least one death at the beginning, and this is that one death that may have been due to this problem. Ever since the FDA issued this guidance in November of 2017, research into the issue has proliferated, and we can now appreciate just how large the scope of the problem is. So that's kind of the bird's eye view of why this is a problem on a mechanistic basis. But now let's dig in a little deeper and talk specifically about what biotin is doing that's causing a problem in these assays, so that we can talk about why sometimes the issue is that biotin will cause falsely high results, and other times, depending on the type of assay, biotin will cause falsely low results. So there are two main types of biotin-based immunoassays: sandwich assays, where high-dose biotin causes false decreases in the measurement, and competitive assays, where high-dose biotin causes false increases in the measurement. Now, in a twist of poetic injustice that Alanis Morissette might call irony, it just so happens that because sandwich assays are used for large molecules and because competitive assays are used for small molecules, and TSH is a large molecule and thyroid hormones are smaller molecules, that biotin winds up creating a false decrease in TSH and a false increase in thyroid hormones, as well as a false increase in thyroid antibodies. It just so happens that if you take high-dose biotin, it makes your thyroid markers generally look like you have Graves' disease, because just, not driven by any actual physiological process going on in your body, it just so happens that the biotin effect throws the markers off in different directions that all happen to perfectly align with the directions that would make someone diagnosed with Graves' disease. Okay, so with that said, here's why biotin has different effects in these different types of assays. Okay, so first, how biotin causes false decreases in sandwich immunoassays. We have to cover a couple of terms. So sandwich immunoassays, in them, we will be concerned with the analyte, which is whatever you are trying to measure in the sample. So for example, if you're measuring TSH, TSH is the analyte because you are analyzing the concentration of it. And then we have a labeled antibody, we have a biotinylated antibody, and we have streptavidin-coated microparticles. The labeled antibody is whatever your machine can actually measure. In most cases, the labeled antibody will give off light. So it is luminescent or luminescent antibody. And you have a machine called a spectrophotometer that will measure how much light is given off. However, it could be labeled in a different way. So, for example, it could have something radioactive attached to it, and you would be measuring it using a machine that detects radioactivity rather than a machine that detects light. But for the purposes of this description, I'm going to assume an assay is using a light-based or luminescent antibody. And so the labeled antibody and the luminescent antibody are the same thing. The luminescence is the type of label, and we could use those terms interchangeably in this case. Now, in order to make a successful measurement, what you want is for the labeled antibody or luminescent antibody, and therefore the amount of light emitted from the sample, to be proportional to the analyte. You want that as the analyte goes up, you have more light given off, or less light, it doesn't matter. As long as the light moves proportionally to the analyte concentration, you have a successful assay. That would require having more labeled antibody than needed to bind all of the analyte, because if you run out of labeled antibody, you're not going to detect some of the analyte. But it also requires that you get rid of any of the excess of labeled antibody, because if you have an excess of labeled antibody and you don't get rid of whatever is not binding to the analyte, then you're just going to have the same falsely high measurement all the time. So you need some way to make all the labeled antibodies stick to the analyte and then get rid of whatever is not needed, whatever's left over. To make that happen, we need the other two components. The biotinylated antibody will bind to the other side of the analyte and anchor it to the floor of the measuring container, which is lined with streptavidin-coated microparticles. So those are the third and fourth elements. Their sole purpose is just to help you hold on to what you have labeled. That is the analyte that you have labeled with the labeled antibody, and to get rid of the rest of the labeled antibody. That's the whole point of these two components. So usually the container is a microplate, which has many small wells for measuring many samples at once. And you put it in a type of spectrophotometer called a plate reader or microplate reader. But it could be a tube or anything else. You could have a variety of containers. It doesn't really matter. The point is that the bottom of whatever the container is, the bottom of that, and I'm going to assume that we're using microplates or plates. So this would be the bottom of the well in the plate, is coated with streptavidin-coated microparticles. If you mix all the components together, you will have all of the analyte getting sandwiched between the two antibodies, bound to the streptavidin-coated microparticles that are lining the plate, with the luminescent antibodies sticking out on top. That's why this is called a sandwich assay. At this point, you wash away the remainder of the luminescent antibodies, and the amount of light emitted from the plate is exactly proportional to the amount of analyte present in the sample. Right? So just to reiterate this, the analyte is what you want to measure. The labeled antibody is how you measure it. The only way you can get your light emission from the labeled antibody to be proportional to the analyte is if all of the analyte sticks to the bottom of the plate and all of the labeled antibody sticks to that analyte, and any excess of labeled antibody leaves. And the way you get the analyte to stick to the bottom of the plate is with the biotinylated antibody and the streptavidin-coated microparticles. So the streptavidin-coated microparticles are they're just stuck with adhesive to the bottom of the plate. They will bind any biotinylated antibody because streptavidin and biotin is the most powerful bond between a protein and anything else that has ever been discovered. And then the biotinylated antibody, because it is designed to bind to the analyte, will make all the analyte stick to the bottom of the plate. And so, like in a sandwich, the biotinylated antibody is the bottom piece of bread. The analyte is the meat, and the labeled antibody is the top piece of bread. And it is there just to cause a measurable signal that's read by the machine. Now, if you find this confusing and it's kind of going over your head, I highly recommend that you use the link in the description to go back to Substack, where I have images that help you visualize what this looks like. Okay, so the problem is, if we have a very high concentration of biotin in the sample because the person was taking high-dose biotin supplements, the biotin itself will bind to the streptavidin-coated microparticles, which will displace the biotinylated antibodies, thereby taking up the spaces needed for the sandwich analyte, causing it to be washed away during the wash step rather than bound to the bottom of the plate. So if you take the sandwich analogy literally, basically what this is saying is, you want to know, how much meat do I have? I know. Let's make a sandwich out of each piece of meat and then count the sandwiches. And then, of course, this analogy is sort of stupid because you could just count the pieces of meat. But due to the nature of physics and chemicals and whatnot, you just so happens that you have to make a sandwich in order to see the meat. Like, you are colorblind to the color of meat, but you can see the color of bread. And so you're going to feel your way through the meat, take one slice of meat, put it in between two pieces of bread, which you can see, and then you're going to look at the bread and you're going to count it. This is the analogy, right? So taking high-dose biotin is basically going to the analogy kind of fails here. For whatever reason, taking high-dose biotin, this is like fake bread that you use for your bottom piece of bread, and it just doesn't stick to the meat, and all the meat falls off the table, and you can't measure it. Okay, the analogy is not that great, but if this is going over your head, hopefully the analogy helps a little bit. Right, so literally what's going on with these molecules is that if you take a high-dose biotin supplement, you have a molecule of free biotin in your blood. I mean, you have many of them, right? But if we reduce this to one molecule to make it easier to talk about, that extra molecule of biotin will bind to the streptavidin at the bottom of the plate. And it is not that's one place that the biotinylated antibody cannot bind to. And so you have one biotinylated antibody that's just going to fall into the trash because of that one molecule of biotin stealing the space for it. Okay, so because of this, high-dose biotin supplements cause false decreases in sandwich assays. Because in a sandwich assay, you should have more analyte, more light. Less analyte, less light. But the high-dose biotin steals the spot that would make an analyte generate light, therefore reduces the amount of light generated, therefore makes it look like you have less analyte when you don't. So high-dose biotin supplements causes false decreases in sandwich immunoassays that are biotin-based. Now we're going to talk about how biotin does the opposite. It causes a false increase in competitive immunoassays. And again, if this is going over your head, I highly recommend you click on the link in the description and look at the images, because the images very much help you understand this. In a competitive immunoassay, everything is the same as in the sandwich assay, but the labeled antibody has been replaced by a labeled analyte. The principle that the analyte will be bound to the biotinylated antibody, which will anchor it to the streptavidin-coated microparticle lining the bottom of the plate, is the same. However, rather than being sandwiched by a luminescent antibody, the analyte competes with a luminescent form of itself provided in the assay kit, which we are referring to here as the labeled analyte. right? So the natural analyte that you're measuring is in your blood or your urine. The labeled analyte is supplied in the kit. In this case, if the constant, and just to go back to the point that these assays require very little technical skill, I'll just make the point that there's a kit. If you're doing liquid chromatography, you don't get a kit. It's like, this is the difference. So an immunoassay is like a microwavable packaged meal that you take out of the freezer and you stick in the microwave. And liquid chromatography is like making a homemade recipe yourself, where at best you get a recipe from a cookbook, but you find that in your kitchen, even the cookbook's recipe doesn't work, and you have to tailor it to work in your kitchen. This requires like orders of magnitude more technical skill, hence why it's more expensive. Anyway, so luckily you get a kit when you run an immunoassay, and in the assay kit you will have the labeled analyte that you need. In this case, if the concentration of the analyte in the sample were 0, all of the binding sites on the biotinylated antibody would be bound by the luminescent analyte from the kit, and the spectrophotometer would read a high signal. The more analyte there is in the sample, however, the more it competes for binding to the biotinylated antibody, making the signal decrease. Now, in one of the images that I have in the written version, again, that's in the link in the description, the image shows that there are 4, and there's just to very much simplify this in a cartoon. In reality, there would be way more than 4 of anything. But it shows 4 streptavidin-coated microparticles at the bottom of the plate. And then there are 4 biotinylated antibodies that bind to them. So all the streptavidin spots are taken up by biotinylated antibodies. But then in 2 of the biotinylated antibodies, you have the natural analyte from the person's blood or urine. And then in another 2, you have the labeled analyte, the luminescent analyte that has competed for the spot. And so what you would have had if it were 0 is you would have had only only labeled analyte in those spots. You would have had 4 labeled analytes in those spots. So you had 2 natural analytes that displaced 2 of the 4 labeled analytes. That has caused a 50% decrease in the signal. Now, if you had twice the concentration of the analyte in your blood, you would have taken up all 4 of those sites, displacing all of the labeled analyte, and you would have decreased the signal to 0, which would have hit the limit of detection on the high end of the range. So, and that would have been because you would have no luminescent signal, right? So what you get here is that a high concentration of the analyte will cause a decrease in the signal that is proportional to the analyte concentration. However, if there are high concentrations of biotin in the sample because you've been taking a high-dose supplement, the biotin will displace the biotinylated antibodies, decreasing the signal without any need for the analyte to be present. And so in the figure, what this shows is that you have the 4 binding sites, and instead of 4 biotinylated antibodies bound to the 4 streptavidin binding sites, you have 1 biotinylated antibody and 3 free biotin molecules, right? They are competing for binding to the streptavidin. They're competing with the biotinylated antibody. And because you only have 1 biotinylated antibody, you don't have enough biotinylated antibody to bind to any of the analyte. And so you're getting a 75% decrease in your signal, even with no analyte there. So it looks like you have a very high concentration of the analyte. Let's say you're looking for TSH, or for thyroid hormone. You could have no thyroid hormone in your blood. And because you have high-dose biotin, the assay would tell you that your thyroid hormone is over the top of the reference range. And that's simply because it, rather than any thyroid hormone, is what's decreasing the signal there by competing for the binding between streptavidin and the biotinylated antibodies. So high-dose biotin causes false increases in competitive immunoassays. Overall, the role of high-dose biotin in both cases is to displace the binding of the biotin-related antibodies to the streptavidin-coated microparticles and to decrease the amount of luminescence measured by the spectrophotometer. And before, as I said, it doesn't have to be luminescence being measured. It could be something else like radioactivity, but we're using luminescence in our schematic. However, whether the decrease in luminescence causes a false decrease or a false increase in what you're trying to measure depends on whether the principle of the assay involves the luminescence increasing or decreasing with the analyte concentration. In sandwich assays, the luminescence increases as the analyte concentration increases, so biotin causes a false decrease in the measurement. In competitive assays, the luminescence decreases as the analyte concentration increases, so biotin causes a false increase in the measurement. And to go back to the example that I gave you earlier, because it just so happens in Alanis Morissette style irony, TSH is a sandwich and it gets a false decrease. Thyroid hormones and thyroid antibodies are competitive and they get false increases. And so high-dose biotin can make you completely falsely look like you have a severe case of Graves' disease when you have nothing wrong with your thyroid at all. Now, there are a great many biotin-based immunoassays that may introduce many variations to this theme, for example, radioactivity instead of luminescence. But what I've presented to you just now is a general scheme for how understanding biotin interference typically works. All right, so having gone through that, what is the scope of this problem in terms of the lab tests? Which lab tests are potentially impacted by high-dose biotin supplements? A recent comprehensive review of this issue characterized the scope of the problem. Whether an assay is biotin-based and how sensitive it is depends on the assay design. Manufacturers of biotin-based assays measure the threshold needed for biotin interference and compare it to the blood values of people taking supplements. There are serious limitations to this approach, but it casts the broadest net, so we'll look at it first. Among common autoanalyzers used by medical laboratories, the platforms made by Roche Diagnostics have 81 assays susceptible to biotin interference, 44 of which are very susceptible. The platform made by Ortho Clinical Diagnostics has 30 susceptible assays, 28 of which are very susceptible. The platforms made by Siemens have 21 susceptible assays, 6 of which are very susceptible. And the platforms made by Beckman Coulter have 15 susceptible assays, 6 of which are very susceptible. Among the most commonly reported interferences in the literature are the following. Section 1. Thyroid function. False decreases in TSH and thyroglobulin. False increases in free and total T4, free and total T3, and all antithyroid antibodies. This could lead to a false diagnosis of hyperthyroidism, the masking of hypothyroidism, or a false diagnosis of an autoimmune condition. The one that I've mentioned to you several times and the one that it most closely, I mean, you can get, it depends what you measure, right? So you're probably most likely to get a false diagnosis of Graves' disease because the doctor is probably going to screen your TSH, and if it's low, they're not going to measure the other antithyroid antibodies that you would see in Hashimoto's, but those will also be falsely increased. So, a conventional doctor might do like a TSH with reflex to T4 so that if the TSH is altered, you then measure T4, but if it's not, you don't. And then, if you initially find low TSH and high T4, then maybe you start measuring other things like anti-TSH receptor antibodies, ultimately leading to the complete picture of Graves' disease. But you can, if you're doing a complete thyroid panel, or you're just looking for Hashimoto's and you're not looking for Graves', you just straight up go to the antibodies. You could also get a false diagnosis for Hashimoto's because all of the antithyroid antibodies are falsely increased by biotin. Section 2. Other hormones. False decreases in parathyroid hormone, or PTH. That can make you look like you get enough calcium and vitamin D. As we'll see in one of the next sections, you also do get false increases in vitamin D. False decreases in parathyroid hormone, luteinizing hormone, and follicle-stimulating hormone. Those are LH and FSH in abbreviated form. Growth hormone, false decreases. False decreases in insulin, C-peptide, adrenocorticotropic hormone. False increases in testosterone, DHEA sulfate, estradiol, progesterone, and cortisol. This could lead to a false diagnosis of a hypoparathyroid hormone, or hypoparathyroidism, rather. It could lead to a masking of hyperparathyroidism. It could, if you pair this with the falsely higher vitamin D that we'll talk about in a minute, this could make, alter your assessment of vitamin D and calcium in terms of making it look like you have enough when you don't. Could lead to the wrong suspicion of a pituitary problem, which could include a tumor that in the pituitary gland that causes disruption of pituitary function, or the wrong suspicion of a tumor somewhere else that is secreting hormones. Section 3, cardiac markers. You get false decreases in troponin and creatine kinase of the cardiac form, with the form that's abundant in heart muscle called creatine kinase MB, and false decreases in NT-proBNP, which is a marker of heart failure. False increases in digoxin, a heart-related medicine. And this can lead to a masking of recent heart attack, a recent case of heart failure, or could make a mistake in dosing a medication. Viral serology. False positives for HIV and markers for hepatitis A, B, and C. Tumor markers, next section. False increases of alpha-fetoprotein, cancer antigen 125, carbohydrate antigen 19.9, and free and total prostate-specific antigen, or PSA. Next section, vitamin markers. False increases in vitamin D, B12, and folate. Pregnancy. Depending on how high the dose is, you can get invalid results as a result from a missing control line, or you can get in pregnant women, or you can get false negatives on a home pregnancy test in women who are pregnant if the dose is high enough. And then allergies, false negatives for IgE allergies regardless of the allergen being tested, at least as far as any of the allergens that have been tested. It's the same effect across the board for all of them, including in patients with anaphylaxis. So now let's look at this, examining studies that simulated high-dose biotin supplementation in vitro. Not all of these tests are equally susceptible. One way to compare them is to look at how they perform when biotin is added to the sample in the laboratory. To do this, researchers use existing estimates of what blood levels of biotin reach on different supplement doses, and then spike the samples with these concentrations. This simulates biotin supplementation in a way that can be used to easily and quickly test the performance of many different assays. One paper looked at the performance of over 30 different assays on the Roche Elixis auto-analyzer platform. Normal concentrations of biotin in plasma are less than 1 nanogram per milliliter. They spiked samples with biotin to bring them to 15.6 nanograms per milliliter to simulate patients taking 5 milligrams of biotin per day, to 31.3 nanograms per milliliter to simulate 10 milligrams per day, and to 500 nanograms per milliliter to simulate the peak concentration reached after a dose of 100 milligrams, or what might be seen randomly throughout the day in someone taking 300 milligrams. With the simulation of 5 milligrams per day, most assays performed with minimal bias. However, the thyroid marker TSH and the cardiac marker troponin T were falsely decreased by 10%. Various antithyroid antibodies were falsely increased by 10%. With the simulation of 10 milligrams per day, the false increase for antithyroid antibodies increased to 50% for antithyroglobulin and more than twofold for antibodies against thyroid peroxidase and the TSH receptor. The false decrease for TSH reached 25%. For troponin T, it reached 20%. For luteinizing hormone, follicle-stimulating hormone, testosterone, DHEA sulfate, and folate, these emerged with 10% false decreases. These last three, that is FSH, not FSH, testosterone, DHEA sulfate, and folate, these last three were paradoxical because models of how the assay works suggest they should be falsely increased rather than falsely decreased, as is found at higher concentrations. Exactly why that happens, no one knows. It was with this simulation of 100 to 300 milligrams per day where things really fell apart. TSH, FSH, insulin, proBNP, troponin T, free and total PSA, PTH, ACTH, all of these had 90 to 95% false decreases, so basically just wiped out from the sample. Folate and cortisol were falsely increased almost twofold. Vitamin B12, progesterone, DHEA sulfate, and estradiol were falsely increased between 2- and 4-fold. Testosterone and free T4 were falsely increased between 4- and 8-fold. The medication digoxin was falsely increased 15-fold. And the antithyroid antibodies were falsely increased between 20- and 60-fold, with the worst of those for the anti-TSH receptor. Another paper used a similar approach to evaluate the performance of the Vitros 5600 autoanalyzer platform produced by Ortho Clinical Diagnostics. They spiked samples to yield 8 different concentrations of biotin between 1.56 and 200 nanograms per milliliter. They only tested 7 different assays, so much smaller study. Troponin 1 and hepatitis antibodies were stable. TSH and prolactin were the most sensitive, suffering false decreases even at low concentrations. Cardiac creatine kinase, cortisol, and the tumor marker alpha-fetoprotein, ferritin, and the pregnancy marker beta-HCG all required 12.5 nanograms per milliliter of biotin to see some effect. At 50 to 200 nanograms per milliliter biotin, most tests were profoundly affected. Cortisol was doubled. Cardiac creatine kinase and TSH were brought close to zero. Ferritin was cut by between 10.4 and 61.5%, depending on how high the concentration was. Alpha-fetoprotein and prolactin were cut up to 90%, and beta-HCG was falsely decreased by 65 to 94%. If you get a 94% decrease in beta-HCG, you're going to get a false negative on your pregnancy test. So that suggests that doses in the 100 milligram per day range are likely to cause very serious errors, including false negatives on pregnancy tests. A paper published earlier this year looked for the first time systematically at allergy tests. Spiking samples from known allergy patients to 300 to 1200 nanograms per milliliter biotin, achievable in the hours after acute doses in the 100 milligram range, could render false negatives for any IgE allergy test. They tested cashews, bee stings, and peanuts, even in anaphylactic patients who have higher levels of the IgE antibodies. While these, which would be a catastrophic misdiagnosis to tell someone who has an anaphylactic reaction to anything that they're not allergic to it. While these systematic in vitro tests are very important for rapidly characterizing the scope of the assays impacted, they are likely to be gross underestimates of the actual problem. So if you look at these in vitro simulations of supplement intake, it looks like the problem is mainly in conventional medicine. The problem is going to be for the very high dose biotin, like in the multiple sclerosis trials. But the optimization in functional medicine is probably going to be seriously impacted by smaller supplements, because if you look at what conventional doctors are doing, they're not going to pay that much attention to small differences in the range. But if you have someone saying, well, the functional range for TSH is actually between this, and it's a much narrower range, then all of a sudden, whether you get a 10% increase or decrease or 20% false increase or decrease, you're going to cause a serious misinformed analysis of what you're optimizing. And of course, if you're looking at it over time and you see a 10% increase or decrease compared to the last test, you think that something is changing when it's not. So I think for tight optimization, the in vitro simulations make it look like you're getting a modest problem with 5 milligrams and a kind of more serious problem with 10 milligrams. Whereas in conventional medicine, it looks like 5 to 10 milligrams is not that big a deal, but 100 to 300 milligrams per day is just utterly catastrophic in terms of like totally destroying any semblance of reality in the lab tests. But again, we're going to look at now why these in vitro simulations actually grossly underestimate the problem. Maybe they don't underestimate the typical problem that much, but in terms of the edge case, in terms of let's put it this way, in terms of the amount of wrong information that can be generated in some people taking as little as 1.5 milligrams per day biotin, these in vitro simulations are grossly underestimating the problem. So, here's why. What I'm telling you now is why the mechanisms of why in vitro tests are likely to underestimate biotin interference. Then we're going to go into actual evidence that that's true. So this is why we should expect in vitro tests to underestimate the biotin interference. First of all, in a live human being, a large portion of biotin breakdown products called metabolites, the things that biotin is metabolized into, are present in the blood and urine alongside the biotin. Some of them, not all of them, also bind to streptavidin. Thus, it is the concentration of biotin and all its streptavidin binding breakdown products, not merely of biotin itself, that will determine the level of interference, which means that systematically you will have more interference than the in vitro simulations suggested, because none of them were testing biotin alongside an additional amount of biotin metabolites. Second of all, large molecules bound to biotin will also bind to streptavidin. These have traditionally been filtered out of samples when measuring biotin in the samples for this very reason. So if using avidin or streptavidin to say how much biotin is in the plasma or urine, they've always filtered out the large molecules so that they didn't get false increases in the amount of free circulating biotin. In other words, if you got enzymes there that have biotin stuck to them and the shape of that enzyme is such that it would be accessible to streptavidin, it's going to bind to the streptavidin. But you're not trying to measure the enzymes, you're trying to measure the circulating biotin. And so the lab tests have always filtered out large molecules. But the lab tests don't filter samples of large molecules for routine lab testing of all the other things using the biotin-based assays. So you're probably going to have additional interference from biotin-bound large molecules, as well as biotin metabolites. And then finally, people with kidney problems is reason number 3, and perhaps other illnesses such as impaired liver function, will accumulate more biotin in their blood than normal, and thus have a greater degree of interference on lab tests. After an acute dose of biotin in the 0.5 to 20 milligram range, 45% of the biotin excreted in the urine is biotin metabolites. In plasma, 25 to 40% of a 1200 microgram dose is biotin metabolites, and this stays stable after 2 weeks of taking the supplement on a daily basis. While biotin metabolites have strong competition with biotin for binding to egg white avidin, their binding to the streptavidin used in most modern immunoassays is less significant. Some of them have no appreciable binding to streptavidin at all, and others bind about 10% as strongly as biotin does. This suggests that in vivo results should show smaller rather than larger differences for biotin interference when compared with in vitro results. Based on this consideration alone, we'll see that that's not the case. However, streptavidin binds to unknown interfering substances in human urine that egg white avidin does not. And if we don't know all the streptavidin binding substances in human samples, this really strongly underscores the importance of conducting biotin interference studies in live humans, because obviously more is going on under the hood than simply free biotin binding to the biotin-related antibodies. Other stuff can bind, to the streptavidin in the assay. Other things will be in biological samples that can bind it. Another problem is that individuals with impaired kidney function may accumulate much more biotin and biotin metabolites than those with normal kidney function. Remarkably, a PubMed search for biotin and chronic kidney disease, or CKD, reveals only a single human study showing massively high vitamin B12 levels in CKD patients. The authors of that study suspected biotin interference, but they, quote, ruled out, unquote, biotin therapy based on, quote, a thorough patient history, end quote. Bizarrely, they did not measure the serum levels of biotin. If House MD were here, he would say, patients lie. They lie all the time. Why didn't you measure the serum levels of biotin? It's also possible that, and I'll step in to be a little bit more polite than House would be, but patients do not always know what supplements they're taking, especially if they're taking a dermatological supplement that's like healthy hair and nails, and it has 5 milligrams of biotin, and they have no clue because they never looked at the label. So there was no basis, in my opinion, to rule it out just based on the fact that it wasn't noted in the patient history. In any case, it's also possible that impaired kidney function alters the distribution of metabolites or leads to the accumulation of biotin-bound proteins that are capable of binding to streptavidin. This is supported by a case of falsely low PTH in a kidney disease patient. The patient was supplementing with 10 milligrams of biotin per day. Her PTH was high, but falsely measured as low. The authors measured the biotin in her blood, and it was 4.8 nanograms per milliliter, which is high, and kudos to them for actually measuring it. However, the assay manual said that this concentration of biotin was insufficient to create interference. Moreover, when they spiked a control sample with 4.8 nanograms per milliliter of biotin, it did not create any interference. So they independently verified what the lab had found, what the manufacturer had found, that higher than that concentration is needed to cause interference. However, removing the, quote, biotin from her blood using streptavidin got rid of the false PTH suppression in her sample. When she stopped the supplement for 2 weeks, this also removed the false PTH suppression in her sample. Therefore, the 10 milligrams per day biotin supplement was causing something other than free biotin to accumulate in her blood that was capable of binding streptavidin and was causing interference in the assay, in complete contradistinction to what the manufacturer's manual said for the assay should happen, and what the authors independently verified using the standard procedure that the manufacturers used to test biotin interference in their assays. In other words, the in vitro simulations were utterly worthless to show what 10 milligrams per day of biotin would do in this patient, because the in vitro simulations were based on the biotin concentration, but the biotin supplement is causing something else that binds to streptavidin to be in her blood that isn't biotin, that is causing interference. So therefore, the in vitro simulations are utterly worthless in this case. So, I mean, they're not utterly worthless. That what they're worth is they set the absolute lower bound of the problem. Searches for liver disease and serum biotin, and they set the lower bound, and they show that it's massive, affecting hundreds of lab tests. But that is the absolute lower bound of the actual problem, which is far greater. Searches for liver disease and serum biotin do not reveal anything looking at whether liver disease can alter serum biotin levels. However, there is evidence from rats that liver has a biotin storage system, so perhaps liver damage can also raise serum biotin. The Mayo Clinic study that I talked about at the beginning of this measured biotin levels. What I had told you about was their survey of the people, but they also measured biotin levels in 1,442 blood samples left over from electrolyte measurements in the emergency room. Unfortunately, their assay had a limit of detection of 5 nanograms per milliliter, which is more than 5 times the top of the normal range. 48% of the samples had biotin concentrations higher than this. It is not normally possible to have biotin concentrations this high without high-dose supplements. Yet their outpatient survey revealed only 7.7% of respondents taking high-dose supplements, which is consistent with the number of women over 60 taking such supplements nationally, but completely at odds with 48% of the samples in the emergency room blood used for electrolyte testing showing what would appear to be evidence of high-dose biotin supplementation. So either biotin is putting people in the emergency room in droves, or people with emergency medical problems are typically reaching for the high-dose biotin on their way to the ER, both of which sound incredibly unlikely to be the case, either of them. The remaining possibility is that illness, at least from kidney impairment and perhaps from liver damage or other mechanisms, is driving serum biotin upward in emergency room patients who need their electrolytes tested. And of course, kidney problems would be one of the reasons you would test someone's electrolytes in the emergency room. One of them. CDC estimates that CDC. Anyway, CDC estimates that chronic kidney disease impacts 14% of Americans. From the literature, non-alcoholic fatty liver disease impacts 20 to 30% of individuals in Western countries, including Americans. So, biotin interference in live humans is likely to be worse than in vitro simulations suggest because of the presence of biotin metabolites and biotin-bound proteins, and who knows what else caused by biotin supplements in human samples. And because people with kidney disease and perhaps other illnesses are likely to have greater than expected accumulation of these substances, and possibly because they have an altered distribution of them as well. So that underscores the need for the in vivo studies, but now let's look at what we have for in vivo evidence, which is very limited. A small study of 6 individuals measured 37 assays for 11 analytes across 4 platforms before and after the 6 individuals took 10 milligrams of biotin per day for 7 days, and then after stopping the supplement for another 7 days. So what did it do from baseline? What did a week of taking 10 milligrams of biotin per day do? And then what did a week of stopping it do? This was a before and after study rather than a randomized controlled study, and they didn't compare the biotin-based tests to other tests not based on biotin. So there's some possibility that there was a real effect of biotin. Maybe biotin does decrease TSH. However, the results are consistent with what we know about biotin causing false alterations on these tests, and it's the only systematic investigation of many assays in live humans supplementing with biotin, so we need to take a look at it and use it to calibrate basically how we should adjust the in vitro simulations towards a more realistic view of the problem. So the supplement decreased TSH by 1.67 milli-IUs per liter on the Vitros platform, but only 0.72 on the Roche platform. PTH was decreased by 25.8 picograms per milliliter on the Vitros platform, which is nearly half of the reference range. 25-OHD went up 9.25 nanograms per milliliter on the Roche platform, which is enough to misclassify many people with suboptimal status as having optimal status. Pair these together and you have a situation that, from my optimization standpoint, is almost as bad as the clinical, the conventional clinical diagnosis of Graves' disease. Because if you go to, say in testing nutritional status, the ultimate cheat sheet, my complete system for managing nutritional status, we look at whether PTH is maximally suppressed, which it usually is on average in the bottom half of the reference range. Well, simply taking high-dose biotin is going to falsely put you in the lower half of the reference range by taking off the top 26 picograms per milliliter, and it's going to make your 25-OHD go up. So it's going to look like you fully optimized your vitamin D and calcium status because your 25-OHD went up, your PTH became maximally suppressed, when maybe you did nothing and you're significantly deficient. In this study, thyroid hormones were fairly stable, but on the Roche platform, total T3 increased above the reference range in half of the subjects. Now let's compare this paper where humans took 10 milligrams a day to the in vitro simulations of 10 milligrams per day cited above, looking at both that bigger Roche study and the smaller Vitros study. So for Roche TSH, the simulation found a 25% decrease, but the human study found a 67% decrease. Thus, the simulation underestimated the effect by 2.7-fold. So it's the real effect is almost 3 times worse than the in vitro simulation makes it look. Now, for vitro TSH, the simulation found an 87 to 96% decrease, while the human study found a 96% decrease. Thus, the simulation was fairly accurate. But note that the simulation was accurate for the terrible prediction of a 96% abolition of the TSH in the sample. But in the Roche study, which found a less severe 25% decrease, that's where it was underestimated. So, these are the only 2 examples where we can clearly line up what the in vitro simulation tried to do versus what the in vivo study did, just because the analytes they're measuring and where that lines up with the same analyte on the same platform being tested in the in vitro simulation. But so it's a sample of 2 to make the comparison, but what it seems to suggest or is consistent with is that when the in vitro simulation makes it not look utterly catastrophic, it's a gross underestimation. And if the in vitro simulation suggests that it's grossly catastrophic, then it's fairly accurate. So, so the very limited data in vivo suggests that the situation is very bad. So, it's sufficient to illustrate the point that the in vitro simulations can sometimes, but not always, be gross underestimations of the interference found in vivo. That's the conservative interpretation here. And if you want to be more liberal with our sample size of 2, if the in vitro simulation says it's not that bad, it's probably terrible. And if the in vitro simulation says it's probably terrible, it's terrible. So somewhere between those 2 conclusions you can draw. All right, now let's move on to case reports, where we talk about unnecessary medications, unnecessary surgeries, misdiagnoses, and psychological distress. And this is not a comprehensive review of the case reports for biotin interference, but what I did was I selected examples that illustrate the several major different problems that you could run into. And so this will help us see the clinical impact of the problem and the realistic worst case scenarios in the case reports. Unnecessary anti-thyroid medication. In a series of 6 children taking between 2 and 15 milligrams of biotin per day for inherited metabolic diseases, all 6 were found to have apparent Graves' disease during routine lab work. They had high thyroid hormone levels, low TSH, and high levels of anti-TSH receptor antibodies. Only 1 child had symptoms consistent with hyperthyroidism, tachycardia, fast heartbeat, restlessness, and failure to thrive. Given that he had an inherited metabolic disorder that he was being treated for with the biotin, there's no particular reason to think those symptoms are specific to the thyroid. At least 3 of the children were started on anti-thyroid medication. All of the abnormal blood work normalized after stopping the biotin supplements for 1 to 7 days. And so notice that obviously the tachycardia, restlessness, and failure to thrive in that child was not due to Graves' disease, because even in that child, the Graves' disease blood work was fake, caused by the biotin supplement. The antithyroid medication might have harmed the children who took it, and the authors did note that, but they didn't pursue that possibility in any detail. A similar case is found in a 32-year-old man. His general practitioner found low TSH and elevated thyroid hormones and referred him to an endocrinologist. The endo found no clinical signs of hyperthyroidism. However, quote-unquote positive antibodies to the TSH receptor, quote-unquote confirmed Graves' disease, and the patient was given antithyroid medication. When it was time for follow-up, his endo was on vacation, so he was referred to a hospital. Thank God his endo was on vacation. Surprised by his, quote, frank and severe, quote, biochemical hyperthyroidism, unquote, despite, quote, no signs of thyrotoxicosis, unquote. The hospital physicians noticed that all his blood work had been done at the same lab, so they repeated all of it in-house, where they used a different platform. And guess what? All of the results turned out to be normal. It turned out he had been taking 300 milligrams of biotin per day as part of a clinical trial for X-linked adrenomyeloneuropathy. His unnecessary antithyroid medication was then stopped immediately. The authors chose a somewhat bizarre title for this case report. The title was "A Somewhat Bizarre Case of Graves' Disease Due to Vitamin Treatment." This title itself is somewhat bizarre because the patient didn't have Graves' disease, and the vitamin treatment didn't cause any disease. Rather, it was a somewhat bizarre case of a false instance of Graves' disease caused by false lab work that was caused by the vitamin treatment. Unnecessary surgery. In a 15-year-old girl with Dennis-Drash syndrome, biotin interference led to unnecessary removal of her ovaries. This is a disorder involving impaired kidney function and usually in males, abnormal sexual development. In this case, the girl did have abnormally developed sexual organs. And so, based on the report in the paper, I don't think she would have been fertile, but that doesn't excuse taking out her ovaries for no reason. So she had high testosterone, and based on previous cases, the physicians were worried that she had a testosterone-producing tumor, so they removed her ovaries. However, no such tumor was found during the removal. Her testosterone remained high, at which point further questioning revealed she had been taking high-dose biotin for 8 months for hair loss. Her testosterone was then remeasured using liquid chromatography and shown to be normal, and the original immunoassays also showed her testosterone to be normal after she stopped taking biotin. Now, yes, they were worried about the tumor, and yes, that might have justified the surgery, but look at how trivial what they would have had to do to figure out the problem. Further questioning, number one, and reanalyze the blood using liquid chromatography, number two. Maybe they should have done that before they took out her ovaries. I mean, this is wild, right? Like, they removed her ovaries, and that didn't work to lower the testosterone, which motivated them to ask her questions to reveal that she was supplementing with biotin. Maybe you should ask the patient if they're supplementing with biotin before you do the surgery. Anyway, they don't report the dose of biotin she was taking, and they claim that her serum biotin levels were 800 milligrams per liter, which is 800 micrograms per milliliter, and 800,000 nanograms per milliliter. This is orders of magnitude higher than what would be expected from 100 to 300 milligrams per day, and I'm guessing maybe a calculation error or an error in reporting the units. However, if it's true, it would be supportive of her kidney impairment backing up her biotin clearance. And that would suggest that the renal impairment is a vastly larger. If those units are right, that suggests that renal impairment is a vastly bigger problem than even I was suspecting based on the Mayo Clinic emergency room data. The false testosterone, and that just underscores how crazy it was that previous case series where they suspected that the massively high B12 in the kidney patients was due to biotin interference and ruled it out by finding no evidence of biotin therapy in the clinical history. How ludicrous that was, because maybe they weren't taking any supplements and the renal impairment raised their serum biotin levels. Because they are eating some biotin, right? So, but I'm still very suspicious that they made an error in reporting the units for that, because that's insanely high. Now, had the false testosterone measurement been discovered prior to the surgery, she would not have had the surgery, and even if it's the case that she might have been infertile anyway, my guess is she would not have wanted to undergo a completely unnecessary surgery. All right, psychological distress and near misses for unnecessary surgery. A 48-year-old woman came to an endocrinology clinic with heart palpitations, difficulty losing weight, and hirsutism, which is hair growth in a typically male pattern on a female. She had been taking 5 milligrams per day regularly of biotin for 6 months and intermittently had been taking that same dose for 5 years. She had a multitude of aberrant hormone measurements that led to an MRI of her pituitary gland to look for a tumor. Then she was referred to the reproductive endocrinology unit to look for a testosterone-producing tumor or an ovarian hyperthicosis, which is an overgrowth of part of the ovaries. Her pelvic ultrasound was unremarkable, but couldn't rule out a small testosterone-producing tumor, so she was scheduled for a hysterectomy and an oophorectomy, which are the surgical removals of the uterus and the ovaries. Oophorectomy, also called an ovariectomy. Luckily, 10 weeks after her initial presentation and before her scheduled surgery, this is the model, right? Like, schedule the surgery and then do the follow-up before you do the surgery. Okay, luckily, 10 weeks after her initial presentation and before her scheduled surgery, additional results using liquid chromatography. Oh, you can do it before you do the surgery. Look at that. Rather than an immunoassay, showed that all her hormone levels were totally normal. The patient stopped taking biotin and then repeated the immunoassays 2 weeks later, and they too were normal. This led to weeks of psychological distress and almost resulted in an unnecessary surgery. Kudos for doing the additional follow-up before the surgery. Interestingly, a 2017 report of a different case of falsely elevated sex hormones actually did result in a totally unnecessary hysterectomy and bilateral oophorectomy, and the source of the false elevations was never identified. All that was shown was that the clinical picture contrasted with the results of the immunoassays, and that liquid chromatography results showed the immunoassays were wrong, and the authors ruled out biotin interference because, quote, our patient did not use biotin at the time of testing, end quote, but they did not measure her serum biotin. Q-House MD, patients lie. Why did you believe the patient? Q. Chris Masterjohn, the patient might have been taking a high-dose biotin supplement that was called something else because it was a complex of things for hair, skin, and nails and had milligram amounts of biotin in the ingredients, but the customer took the supplement without looking at the ingredients, and maybe the patients had other things that were raising their serum biotin in response to smaller amounts in a multivitamin or even food. And so that's why if you suspect biotin interference, you measure the serum biotin rather than asking the patient if they're consuming enough biotin to interfere with the lab test. I have a suggestion for clinicians. If you suspect biotin interference, measure serum biotin. The end. All right. Confusion around necessary surgeries. In 2 women in their 60s, PTH was rendered undetectable from biotin interference. The first woman was suffering from primary hyperparathyroidism that was causing high serum calcium, osteopenia, fractures, and chronic kidney impairment. Her problem was her PTH was too high. And if any of you were wondering, well, why didn't they just give her vitamin D and calcium, since I was saying before that not having enough raises your PTH, the thing is, the high serum calcium suggests that if your vitamin D and calcium are low and that's driving your PTH to go up, it's because your PTH wants to prevent the calcium from dropping low and bring it back to normal. But if the PTH is driving high serum calcium, then that suggests that there's a primary hyperparathyroidism, meaning the hyperparathyroidism is not secondary to nutrition. It's primary, meaning it's something wrong with the gland, because it's not more PTH trying to bring calcium up to normal. It's more PTH than you need to do that, causing high serum calcium. So that's the defining feature that makes this look like primary hyperparathyroidism rather than just a calcium deficiency. Although, you know, I'm not so sure that she wasn't also not consuming enough calcium. So, and now you might say, well, it doesn't matter because her serum calcium was high. You don't want it to go any higher, and that's not necessarily the case, because if the parathyroid gland is not completely dysfunctional and the calcium is deficient, then the PTH is going to be higher than it otherwise would be because of a calcium deficiency. And not all serum calcium is equal. If you're getting serum calcium that's being driven by bone resorption from the PTH, that is more likely to cause calcification of the kidneys, because you don't get complete ionization of it, and you get some crystals that will crystallize in the kidneys. And if the calcium is absorbed from the gut, it's going to be completely ionized. And so ionized calcium does not cause the same degree of kidney impairment as crystallized calcium released from the bones. And so you want, in all cases, to always be deriving as much calcium as you can from your diet and as little calcium as you can from your bone for the sake of your kidneys. And so I am not so sure that, there might have been some degree of primary hyperparathyroidism. I'm not so sure it makes sense to go right to surgery without looking at the diet, the nutritional factors that could be aggravating it. But nevertheless, her problem was her PTH was too high. They diagnosed primary hyperparathyroidism, and she was preparing to have it surgically removed. And as she was preparing, her PTH became undetectable. This made no sense because her serum calcium was high, and PTH raises serum calcium. And if PTH is undetectable, your calcium should be fatally low. It turned out that she was taking 1,500 micrograms or 1.5 milligrams per day of biotin for hair growth. She stopped taking the biotin, her PTH was repeated a month later, and it was normal. To make the biotin interference clearer, she restarted the same dose, measured the PTH again, and it disappeared. 1,500 micrograms is way too low to do this, according to the studies I reviewed above with the in vitro simulations and the in vivo study of 6 people. This patient's elevated PTH was causing chronic kidney impairment, however. Thus, her serum biotin, which was not measured, pull my hair out. Her serum biotin was probably much higher than you would expect from her supplement, and she may have had an altered distribution of biotin metabolites or biotin-bound proteins. And so even in this case, where they knew it was the biotin, they would have done a great service to humanity if they had measured the serum biotin and included the measurement in the case report. In the second case from the same report, this second woman in her 60s had elevated PTH causing elevated serum calcium and kidney stones for some 10 years. And then more recently, leading up to the case report, she was suffering from muscle pain. Her parathyroid gland was partly removed and her PTH and calcium returned to normal. At 6 and 9 months out, however, her PTH became undetectable. Most likely it was because she was taking 5 milligrams of biotin per day for neuropathic pain. They didn't measure serum biotin or try the start and stop with the supplement to prove it, but that lines up with what happened in the other patient of theirs. So this has not been a comprehensive review of case reports and case series. I selected specific cases that help illustrate some of the clinical harm that comes from biotin interference. But this goes to show that this causes unnecessary antithyroid medication, unnecessary surgery, near misses for unnecessary surgery, psychological distress, and confusion around necessary surgeries. And as we said before, possibly it's leaded to one death in the failure to manage severe cardiac problems. It could be a heart attack or heart failure that's missed because of this. Okay, so that's the scope and the magnitude of the problem. And then just to just to very much reiterate, the case reports show us that as little as 1.5 milligrams of biotin can make PTH undetectable, which shows that in some people, and remember, maybe this is driven by kidney problems, but people with PTH problems are going to tend to have kidney problems, right? So this is when you care is when you have the problem, which is not good. And this shows you that the edge case that can happen, right? And you don't care about the median case. Like you really don't care if the average person who has no problems has something changed by 10%. You care whether you miss the person who has a problem. So if the people with the problems are more likely to have the interference problem, then actually your problem is really massively big. Because if it's specifically selecting for the people who have a kidney problem where as little as 1.5 milligrams of biotin is going to make PTH undetectable, then it's specifically in the cases that you need to find where you don't find the case because of an amount of biotin that's way under what all the other studies suggest, right? So the case reports show us that when it matters, as little as 1.5 milligrams of biotin can cause not a modest change, but a flat-out total non-reality result that makes no sense. But, where it makes no sense is where you find it. If it makes complete sense that the person has Graves' disease and that complete sense is also false, or it makes complete sense that you need to remove the person's ovaries and that complete sense is also false, then you're less likely to find it because you didn't say, hey, this makes no sense. Let's look for a reason why it's happening and find the biotin supplementation. You said, this makes complete sense. Operate now. Add the anti-thyroid meds now, right? So the case reports show us enormous clinical harm that can come primarily for the false positives of things where you would take clinical action, whereas mainly confusion results from things that don't make sense that would not lead to clinical action, although the inaction could lead to clinical harm from delaying the treatment someone needs, which might be a surgery or which might be treatment for a heart attack or heart failure. All right, so what can we do about it? What can be done about biotin interference? Up to this point, laboratorians have had various ways to look for and correct for interference. For example, if results are anomalous, they can perform a serial dilution. This means yielding a string of repeated dilutions such as 2x, 4x, 8x, 16x. It doesn't have to be doubled each time, but it could be any kind of linear increase in the amount of dilution in the series. And this, if everything's normal, this should yield analyte concentrations proportional to the degree of dilution. So you just mathematically correct for how much dilution you did, and you get the same result in every dilution. If you don't get that, if you have non-linearity in response between your dilution and the analyte concentration that you get in those samples, that's a sign of interference. Sometimes simply diluting the sample will bring the interfering factor, in this case biotin, down low enough that the assays perform normally. But sometimes they don't. And sometimes you can't dilute it that much because the actual dilution brings the analyte concentration into a problem where the assay doesn't work correctly. So if biotin interference is suspected because of the serial dilution or for some other reason, such as a discordance between the results and the clinical suspicion, then the laboratorian or the lab technician can do several things. One would be remove biotin from the sample using streptavidin-coated microparticles before making the measurement. Another would be use liquid chromatography to repeat the measurement rather than immunoassay. And the third would be to alert the physician and patient and retest the sample after the patient stops taking the biotin. However, all of these techniques are very time-consuming, and liquid chromatography, as we said before, is more expensive than immunoassays. So to do this systematically is a very high burden on the cost structure of the medical system. Thus, lab manufacturers and methodologists have been working hard for the last several years to make immunoassays immune to this problem. One innovation that was published this year is a synthetic mirror image streptavidin. Many molecules are capable of a phenomenon known as optical isomerism. They can exist in two mirror image forms, each of which rotate light in opposite directions. The mirror images that rotate light leftward are designated L for levorotatory, and those that rotate light rightward are designated D for dextrorotatory. This is true of both the streptavidin and biotin. Natural streptavidin, because it's a protein, is made of L amino acids, and natural biotin is D-biotin. D-biotin is also the form found in high-dose supplements. Scientists have now made a synthetic streptavidin composed of D amino acids that binds tightly to synthetic L-biotin. Since D-streptavidin will not bind to D-biotin, the assay can be based on D-streptavidin and L-biotinylated antibodies, and supplementation with D-biotin will not be able to cause interference. Another method was published this year to increase the number of streptavidin microparticles per sample in a fully automated platform. This pushes up the number of binding sites so that it becomes irrelevant whether large amounts of biotin compete for them. And this has the advantage that you don't have the human error involved in a non-automated solution, such as cleaning out the biotin from the sample with streptavidin before you process it. And also it's less time consuming because rather than doing the cleaning step, it's just integrated into the same normal steps of the assay. While this may seem obvious in retrospect, the microparticles themselves can block the light signal, and too high of a concentration can interfere with the assay. Thus, work had to be done in designing microparticles that could be added in higher concentrations without blocking too much of the signal. Nevertheless, while lab assays will likely have this problem solved in the future, right now, physicians and patients have no control over the degree to which the problem is solved, and they also have no control over the skill of the lab technicians in recognizing biotin interference. Therefore, physicians need to ask their patients about biotin intake, remind them to stop taking biotin before any lab tests, and be aware of biotin interference as a reason for anomalous lab results that conflict with the clinical picture. As a reminder, it's always best to ask about this before you do unnecessary surgery. Individuals have no control over their doctor's knowledge in this area, and they need to take the initiative to stop taking biotin before any lab tests, not wait for their doctor to tell them to do that. But for how long do we need to stop taking biotin before lab tests? Let's talk about that now. Lab manufacturers make claims in their documentation about the threshold of serum biotin needed to cause interference, and often this threshold is 10 nanograms per milliliter or higher. However, we saw above that humans taking 10 milligrams per day have 2.7-fold greater false suppression of TSH on the Roche assay than is found when simulating the intake in vitro. We also saw that a woman taking as little as 1.5 milligrams per day has falsely undetectable PTH. Unfortunately, we do not know her serum biotin, and it was likely higher than we would expect from that dose due to impaired kidney function. We also saw that another patient with kidney disease taking 10 milligrams was generating something other than free biotin in her blood that was causing false suppression of her PTH. Therefore, we should not put all of our eggs in the basket of seeing how long it would take to allow serum biotin to fall into the range that the lab manufacturer says is okay. Rather, we should look at how long it takes to clear serum levels to what we would find in those not taking any supplement, and especially at how long it takes to clear actual interferences with lab tests. A single dose of 600 micrograms of biotin caused the serum biotin to rise from 0.5 nanograms per milliliter to a max of around 3.25 nanograms per milliliter at 1 hour in a small human study. It was cleared from plasma with a half-life of 1 hour and 50 minutes. Generally, 94 to 97% of something is cleared after 4 to 5 half-lives. Thus, a 600 microgram dose should be gone from plasma in 9 hours. From the same study, a week of taking 300 micrograms every day raised the fasting level from 0.75 to 0.94, and another week of 600 micrograms per day raised it to 1.25. The fact that the fasting serum level is increased after repeated daily dosing shows that even after 24 hours, the biotin is not being fully cleared from plasma. It may be that the half-life is rising with cumulative dosing, or that the fasting level represents a natural floor in the circulating biotin that is proportional to body stores, and that body stores were increasing throughout the study. While this study was short, it provides proof of principle that it takes longer for plasma levels to return to baseline when the supplement is taken regularly over time. Doses in the 100 to 300 milligram range have extended plasma half-lives, and taking the biotin with food instead of fasting delays the absorption and extends the plasma half-life. Overall, these high doses have plasma half-lives between 7.8 and 18.8 hours. Basically, the higher the dose, the longer the half-life, and if you take it with food, the longer the half-life. So either the higher dose or eating it with food will push you up toward the 18.8 hour mark. This suggests that it would take 1.5 to 3.9 days to clear most of the dose from plasma. Rounding up, 4 days should be sufficient. There's no data available on how long it takes to clear the biotin levels reached after months of supplementing with these high doses, or with months of supplementing with intermediate doses in the 1 to 10 milligram range. However, or for that matter, even months rather than weeks of the 600 microgram dose. Rather than days, I should say, because that study was 7 days of 300 and then 7 days of 600. However, we do have some data on how long it takes to remove interference on lab tests after stopping biotin. And the data on how long it takes to remove the interference is the best data we can get. In the original case report from the 1990s of an infant with falsely low TSH and falsely high T4, these values appear to normalize after 2 days of stopping the biotin. One author caring for an infant on 30 milligrams of biotin per day with apparently altered thyroid tests performed an experiment on himself by ingesting a single dose of 30 milligrams of biotin. The report claims that many interferences lasted for approximately 5 hours, while thyroid markers, quote, endured for up to 24 hours, end quote. However, the thyroid markers are shown in Figure 1, and when you look at Figure 1, although they are largely recovered, they're not fully recovered at 24 hours, and they didn't keep testing them after that. So most of the suppression is gone in a day, but not all of it. In a group of 10 healthy adults, taking 5 milligrams of biotin per day for 7 days mainly altered thyroid markers for 2 hours. However, TSH and anti-TSH receptor antibodies took a full day to recover. The antibodies were the most affected, and out of the antibodies that were measured, it was the anti-TSH receptors that were most impacted. In a study of lab interferences caused by high-dose biotin in multiple sclerosis patients, 2 of the study authors performed a side study on themselves because they didn't want to take the MS patients off the biotin. So they did a side study on themselves and took 15 to 30 milligrams of biotin per day for 3 days. Funny that they didn't want to do the dose that the MS patients were taking. Anyway, they took 15 to 30 milligrams of biotin per day for 3 days, and interferences with hormone and vitamin D measurements were cleared within 48 hours. In the 6 children misdiagnosed with Graves' disease, stopping the 2 to 15 milligrams per day of biotin that had apparently been taken for months or years, they didn't state the length of time, but these were patients that were diagnosed at some point with a genetic disorder and put on the biotin, so they're probably on the biotin for at least months, if not years. Most of the markers, TSH and the thyroid hormones, took 24 to 48 hours to resolve. But the interference took 7 days to clear on the anti-TSH receptor antibodies. These authors didn't show all of that data, but it sounds from the way they describe it that they were performing daily tests throughout the first week. Other studies and case reports showed return to normal levels after 1 or 2 weeks or after 1 month, but didn't test the other time points, so they can't say it takes 2 weeks to resolve, or it takes 1 week to resolve, or 1 month to resolve, because they didn't compare it to any shorter time period. I'm not aware of any studies showing that it takes longer than 1 week to remove any interference. But there are 2 interpretive problems here. First of all, we have no data on how long it takes to clear biotin from plasma when one has spent months or years on a given dose. And 2, it may be the case that ill people, especially those with kidney disease, take longer to clear biotin, and as well as any other streptavidin-binding substances in their blood caused by the biotin supplementation. It's notable that in the study of 10 healthy adults, anti-TSH receptor antibodies were the most impacted by interference, and along with TSH took the longest to recover, but only took 24 hours. In the 6 children taking 2 to 15 milligrams of biotin per day for very long periods of time, the anti-TSH receptor antibodies took the longest to recover, but in their case, this meant 7 days. Both of these are very consistent with the Roche in vitro simulation that showed that the antithyroid antibodies were the worst impacted, and that out of them, the anti-TSH receptor antibodies were the worst impacted. So the question then is, did the children require 7 days to clear their false positivity on that test because they were children, or because they had metabolic disorders, or because they had been likely taking the biotin for years? It's not clear, but the fact that the dynamic of anti-TSH receptor antibody being worst out of the antibodies and the antibodies being the worst out of the total lab tests, the fact that that shows up in both the healthy adults and the children with metabolic disorders really makes you think it's real. And that this difference between 7 days for the kids and the 24 hours for the adults is also real. In which case, why did the two things come to different results? It's not clear. A few things are clear. The worst thing you can possibly do is take high-dose biotin supplement the morning of your lab test, because for hours, there will be catastrophic levels of interference with all kinds of tests, regardless of the dose you take almost. So you never take high-dose biotin supplement the morning of your lab test. And if it's higher than what you would get in food, you probably should not take it the morning of your lab test. Obviously, if you're fasting, you shouldn't be taking any supplements during the fasting period. The whole point of the fasting is to not have those things in your blood when you're trying to measure them. But I would not take any biotin supplement at all the morning of your lab test, even if it doesn't require fasting. In most cases, most of the problems will be gone with 1 day, but very high doses will generally take 4 doses to clear, and many tests may take 48 hours to clear in some people, even without very high doses. Some tests will take some people up to a week off of biotin to clear. Presumably, this is driven by a combination of the vulnerability of the specific test, the health of the person taking the biotin, and the length of time for which the person has been taking the biotin. That would be the worst result. The worst interpretation of the difference between the healthy adults and the children with metabolic disorders for the anti-TSH receptor is that the bulk of the difference is due to the duration of the supplement. Because if that's true, that means that most of these studies are massively underestimating what someone on the same dose taking it for months or years would be getting, and that we should be using the children with the inherited metabolic disorders as our primary goalpost, or our primary signpost in trying to understand this, because most people who are taking a biotin supplement are going to be taking it for a long period of time, not a short one. And most of these studies had very short durations of biotin supplementation before stopping it to see what the effect on the lab test was. My suggestion would be, so look at this chain of events, right? The in vitro simulations provide a floor of the minimal effect on the largest tested number of lab tests. Then the in vivo results suggest that those effects are much worse than the in vitro simulation. And then the case reports show that the problem is way worse than the short-term human studies. But the case reports, even though they're dealing with sick people, might be the thing we need to use. And these are showing that as little as 1.5 milligrams can have an effect that might take up to a week to get rid of in the case of the worst impacted results being the thyroid antibodies, and would it otherwise take between 1 and 2 days to resolve for most tests. And we might have to use that if the main reason that the case reports show this is that in the case reports is the only place where people are taking the supplement for a long period of time, such as months or even years. So my suggestion would be stop any biotin supplements over 1 milligram a day for at least 2 days, and preferably 4 days before any lab test. Wait a full 7 days before running thyroid-related antibodies if you have impaired kidney function or if you have been taking the supplement consistently for months or years. If you've been using high-dose biotin supplements, don't make any major medical decisions without making sure that the lab work that they are based on was repeated with liquid chromatography rather than immunoassay. Now, you can be the judge of what a major medical decision is, but basically, don't make any medical decision that you might regret if it were the wrong decision. until you have, so for example, like if your vitamin D was 10 nanograms per milliliter higher, you're probably not going to have profound regrets if you lowered your dose by 1,000 IU for a few months. Whereas you probably will have, no matter who you are, regrets if you made an unnecessary surgery. And then there are many things in between there where you can decide how much you would regret it versus the cost of rerunning the lab work it's based on with only liquid chromatography results. I say this because, I'm not positive that there aren't some people who might take longer than a week for the biotin interference to go away. It's just that, if you're looking at the 80-20 of it, 80, well over 80% of the problem is removed by a couple days of biotin withdrawal on most lab tests. And thankfully, the case report suggests that we can predict how bad the assays are, and that the ones that are most vulnerable are the ones where we want to wait a week. And thyroid antibodies are the prototype of that problem. But, at the end of the day, if it's a unnecessary surgery and you did best practice, you really should confirm the results with some extra legwork if there's any possibility that you tried, you did the best practice that would take care of 98% of the problem and not the 2% edge case. I'm not going to have a surgery if it might be the 2% edge case. So I think if you've been using high-dose biotin supplements, regardless of your kidneys, regardless of how long, and the lab work is done with an immunoassay, and you can look that up and you can, if it's not on the report, you can call LabCorp or whatever and ask them. But if you just if you just look it up on their website, it'll say what the method is, if it doesn't say it in the report itself. And if you've been taking high-dose biotin and that the lab work was done in an immunoassay, and the lab work is the basis for a major medical decision, I think that's the combination where you say, it doesn't matter that I took the biotin out for a week or for 4 days. I'm going to repeat this with liquid chromatography and make sure that that's not the issue before I get the surgery. That's the way I look at it. So the bottom line, doses of biotin greater than 1 milligram per day can interfere with dozens of different lab tests. There are reasons to believe that interference is worse in live humans than suggested by test tube studies and by the assay manuals published by the lab manufacturers. There are not enough human supplementation studies to clarify how long interference lasts using different doses of biotin for different durations and different contexts. Therefore, we should err on the side of caution. The worst thing that you can ever do regarding this issue is to take biotin in any dose the morning of a lab test. Never, ever do this. While many lab tests will normalize hours after taking a biotin supplement for many people, many will take 24 to 48 hours, and some tests, namely the thyroid antibodies, will take some people up to 7 days to clear. Therefore, we should approach this as follows. 1. Never take any biotin supplement before a lab test on the same day as the test. 2. Always stop taking biotin supplements that have doses larger than 1 milligram for at least 2 days and preferably 4 days before any lab tests. 3. Before measuring thyroid-related antibodies, cut out the supplement for a full week if you've been taking it for months or years, or if you have impaired kidney function. 4. If you wish to exercise an abundance of caution, there's nothing wrong with cutting out the biotin for a full week before any lab test in any context. 5. Physicians should always ask their patients about biotin supplementation. Advise them to stop biotin for at least 2 to 4 days before any lab tests, and be aware of biotin interference as an explanation for anomalous results. 6th, and finally, if you've been taking biotin in doses higher than 1 milligram per day, even if you've followed all of the above, do not make any major medical decisions without, meaning any decision you might regret if it was for no reason, without either repeating the immunoassay tests with liquid chromatography to confirm their accuracy or cutting out the biotin supplement for at least 1 month to confirm the results are repeatable. And I would prefer to retest with the liquid chromatography because it doesn't have this problem at all. With all that said, how necessary are these high doses? In high protein, you need more biotin, linked to in the description. I made the case that many people need 150 to 300 micrograms per day, depending on how much protein they eat. My simple food-based recommendations for getting enough of biotin are found in my Cliff Notes, again linked in the description, which are free for MasterPass members and can be downloaded in the ebook section of the Substack website. Certainly, milligram doses are needed for genetic metabolic disorders in biotin absorption and utilization. But do most people taking high-dose supplements need them? That will be the topic of the next episode. Make sure you're subscribed to my Substack at chrismasterjohnphd.substack.com, link in the description, so that you get notified as soon as the article comes out. As a disclaimer, as a reminder, as I said at the beginning, I'm not a medical doctor. This is not medical advice. My goal is to empower you with information. Please make all health decisions yourself, consulting sources you trust, including a caring health professional. Please see the link in the description for the Substack written version of this that has all of the references linked therein. If you enjoyed this, please head over to that link, even if you don't want to read it, so that you can like it, comment on it, and share it to boost the Substack algorithm to get the article before more eyeballs. And then finally, please make sure you're subscribed to my Substack so you can stay immune through the winter. My new 7-page quick guide called Staying Immune Through the Winter on how to not get sick this winter is free for everyone. All you need is a Substack subscription, free or paid. And follow the link in the description to go subscribe. And if you are already subscribed, it's sitting in your inbox. If you didn't see it, it's because you missed the email. So please search your email for Staying Immune Through the Winter and search it for Chris Masterjohn PhD. And for Substack, make sure everything from me and from Substack is going into your primary inbox so you don't miss stuff like this. And when you find any email, so if you find the welcome email, welcome to my newsletter, it's at the top. Say right first thing is here's your free guide to staying immune this winter. But any email from the list will have the download link at the bottom of the email itself. So you can, if you've been on my list for a while, just go back to the last email and you'll get the guide. And if you are not subscribed, of course, if you're a MasterPass member, you can just download it from the ebook section of the menu. If you are not subscribed, please go subscribe. Again, the link is in the description. As soon as you subscribe, within minutes, you'll get welcome to my newsletter email that has the link to Staying Immune, the download link for Staying Immune this winter right at the top. And you'll find all my up-to-date cold and flu defense, preventative, and in the case you get sick, strategies. All right, if you would like to join the next live Q&A to ask a question, then see the links in the description. MasterPass members have access to a monthly Q&A with me. There are other reasons to join the MasterPass. MasterPass members get access to premium content. They get all my ebooks, guides for free, monthly live Q&A sessions, as I just said, all my courses for free, and exclusive access to massive discounts. And you can go to chrismasterjohnphd.com/masterpass to learn more about it, or use the link in the description. Again, please show this post some love. So this is based on the written Substack post. Please head over to that using the link in the description to like, share, and comment. Thank you so much, and have a wonderful day. I'll see you in the next episode.